Good afternoon, everyone. Thank you for joining us. I'm Avital Havusha. I'm the Vice President for Program here at the New York State Health Foundation. As you know, during today's discussion, we'll be focusing on the role that primary care has played during the pandemic and strategies to enhance and strengthen the primary care system as we look towards pandemic recovery. Primary care is a foundation and a key component of a high-functioning and equitable healthcare system, but longstanding underinvestment in primary care continues to be a barrier to maximizing its role. And primary care practices are essential links to the community and to their patients. And as the pandemic has really underscored the importance of these trusted patient-provider relationships, especially now as vaccines roll out, as patients are coming back for care that they might have delayed during the pandemic, and as we address the inequities that were laid bare over the past year plus. So a few housekeeping items before we get started. We'll be recording today's webinar, and a recap will be sent along with the recording and other materials in the next few days. Video and audio are disabled for attendees, but we invite you to chat comments and questions into the chat box throughout our discussion and presentation, and I'll be making sure we pick up on some of those questions towards the end of the webinar. So I'd like to now introduce our speaker, Maura Harris. I'm excited to have her with us today. Maura is the Policy and Advocacy Manager at Primary Care Development Corporation, or PCDC, as many of you probably know it. And she oversees PCDC's local, state, and federal policy efforts and advocacy efforts. And she's been a staunch advocate for primary care, working on these issues for many years. Maura, thanks so much for joining us today. I'm really excited to have you here. And I just want to turn it over to you to just get us started by telling us a little bit more about PCDC and some of how you define the value of primary care.
Great. Yeah, absolutely. Thank you so much, Avital, and I'm really, really excited to be here. To just do a very brief overview of sort of what PCDC does. PCDC is a nonprofit community development financial institution, so we're a CDFI. We were founded about 28 years ago right here in New York City. And since then, we've expanded to work not just across the state, but nationally. And as a CDFI, we provide flexible financing to primary care practices to expand or enhance their facilities. But we also have a technical assistance unit that partners with healthcare providers on the ground to improve their services. And our research and policy unit produces original reports on things like primary care access and leads initiatives aimed at strengthening all things primary care. So to sort of paint the big picture of the value of primary care, like you said, I think it's important to start with what I think makes primary care different, what sets it apart within the framework of the American healthcare system. So primary care is conceptually described sort of as the foundation of the healthcare system, or the first point of contact with the health system. But I think it's really unique in that it's the sector of the health system with the ability to both keep people healthy over the long term and also keep costs down, right? It's the only part of the health system that evidence shows lengthens lives and also reduces inequities at the population level. And there's a vast body of evidence to support that, right? Which I'm sure you're aware. The importance of access to primary care has been so well documented that it's now internationally recognized as a key social determinant of health. But despite all of this evidence, as you sort of alluded to, primary care is really chronically undervalued and underinvested in the US. Primary care providers across the state that have really shown just exceptional resilience in the face of extreme adversity over this last year of the pandemic really need increased support and investment. And PCDC has been working to do that for years. So I'm just really excited to be here to dig into the issues and opportunities surrounding access and quality.
Thanks, that's really helpful. So why don't we start there? Maybe you could tell us a little bit more, kind of from your perspective, how primary care practices have fared during the pandemic, and patients as well. What role have they played? Where could there have potentially been some more support, and maybe where are we seeing some support coming?
Yeah, it's a good question. So there's a lot there. So I think the short answer, right, is is really that primary care has suffered over the past year. I mean, I think COVID was really illustrative of the fragility of the primary care payment and delivery system. For the majority of this last year, primary care providers faced unprecedented challenges with very little support. I mean, if we go back to the very beginning of the pandemic, by April of last year, ambulatory care visits were down by 60% in some places. And that resulted in a really drastic drop in revenues and forced a lot of practices to furlough staff, lay off staff, or even close their doors. And during this time, a lot of the federal financial aid that was being issued was really focused on hospitals, and rightly so, right? But very few of those dollars were ever really designated for primary care, and so therefore, they failed to reach a lot of practices that were suffering. And I think this dip in visit volume had sort of secondary repercussions as well. It wasn't just hurting the providers. You mentioned this as well, but last spring, a lot of experts were warning of what they were calling a second pandemic, going to be resulting from foregone care. And, just a lot of people were just adhering to social distancing guidelines, or just for fear of contracting the virus, were putting off their regular preventive care visits or chronic disease management. And unfortunately, we're actually already seeing some of the effects of this. There was a recent report that came out that showed that 1 in 3 excess deaths in the US between March and August of last year were actually unrelated to COVID. So there's all of that, right? But I think on top of that, more than anything, COVID has really just laid bare the inequities that already existed in New York State and nationally, and really just exacerbated them. And I have a couple of slides here with some data that I think really illustrates that. So let me just pull that up here. Great. So we got some maps here. So these maps were taken from a PCDC produced report examining the geography of COVID cases in New York City as of May of last year. The data is at the zip code level. And so as you can see, the darker colored zip codes in the red map represent a greater density of COVID cases per population. And those areas correlate with the darker colored zip codes in the blue map, which represent a lesser density of primary care providers per population. So in New York City, at least, right, many of the neighborhoods with the least primary care access had some of the worst COVID rates. Now, of course, we can't draw the hard line of causation here, but I think that the correlations are really illuminating. And one of the starkest statistics that came out of this analysis from PCDC was actually that Steinway, Queens, which had the highest COVID case rate citywide back at the height of the pandemic. It was actually 6.4 times higher than that of East Village in Manhattan. But East Village has 79 times more primary care providers per 10,000 residents. So really stark disparities here in regard to primary care access. But I think unsurprisingly, PCDC's analysis also found that many of those same neighborhoods with the least primary care access and the highest COVID rates were also home to a disproportionately high number of Black and low-income residents. So, PCDC and other experts and advocates have really been keenly aware of these disparities for decades, right? But I think that this has really been brought to the forefront of the policy discussion over the last year. And so I think we're hopeful that that lawmakers will see this year as one of reckoning and really take action to relieve the suffering of these communities by working to increase access to quality primary care.
Great, thank you. And, I think that maybe can bring us a little bit more to that's really helpful to kind of frame the conversation, with some of that evidence from the past year. Maybe let's shift a little bit now to, some of the strategies and solutions. What can you speak a little bit more about as we look towards this pandemic recovery period and how primary care has been and can play an increased role in kind of building back better a healthcare system with primary care as a central component? What types of support do primary care practices and providers need? What's happening maybe we'll start with the short and the medium term, and then we can turn to the longer term?
Sure, yeah, that's a great way to do it. So I think things have certainly started to improve over time, right? There's actually a recent national survey that showed a 200% increase in health screening activities since last year, May of
Hmm.
last year, which is great, right? So I think that there's this sort of flood of pent up demand for care that's been exacerbated by worsening mental health and social vulnerabilities that have resulted from the pandemic. And this is all happening right as the primary care sector is beginning to be leveraged to target the vaccine to communities that need it. So I think in order to support primary care to be able to succeed in meeting this demand for care and vaccine distribution, there are a few things that we can be doing. To your point, in the sort of short and medium term, I think first it's really important to acknowledge that there have been some really meaningful successes for primary care in recent months at both the state and federal levels. So at the federal level, HRSA just announced more than $6 billion in funding for health centers and lookalikes to support them in their recovery efforts. And I think that this infusion of federal dollars is just really going to be helpful for these community-based providers who have been instrumental in providing care to our most vulnerable populations during the pandemic. I mean, as you and I both know, Avital, many New York communities depend on safety net institutions like FQHCs. They're anchor institutions and provide really comprehensive services that aren't accessible elsewhere for the people that they serve. So that's going to be really important. And then at the state level, the enacted budget included several actions actually surrounding telehealth to make permanent a lot of the regulatory flexibilities that were instituted under the public health emergency. So this is also incredibly important because we've seen telehealth become, not only a financial lifeline for
Hmm.
providers, but also a mode of care delivery that is really effective and beneficial for a lot of patients, right? So I think that that's sort of some short-term successes, right? And in this more medium term, the things I think we should be focusing on are, for one, just continuing to promote utilization of primary care, right? I think the state, municipal governments, public and private payers should be using all available channels to elevate the importance of primary care, both during this unique pandemic moment and also beyond. And then I also think that we should be thinking about tapping into opportunities to bolster more patient-centered and integrated care models. So for instance, I know that there's a consideration of an integration of the two state agencies that handle mental health and substance use services. And there's also consideration of the creation of a single set of licensing requirements across all three agencies, including the Department of Health for the provision of outpatient services. And so I think it's initiatives like these that provide a prime opportunity to further expand the integration of primary care into behavioral health settings and behavioral health into primary care settings, right? It goes both ways. Um, Now more than ever, I think we're seeing mental health needs continue to rise, and the current regulatory requirements that create this maze across these
Hmm.
agencies are sort of a burden. So, primary care access in poor and minority communities has been hampered by this unnecessary complexity. So now I think is really the time to act on these initiatives. They'll have really, really huge beneficial effects downstream.
Got it. Thank you. No, that's helpful. And then if we think about that kind of in the context of maybe some of the longer term solutions and strategies that initiatives that people are considering, I know PCDC and some of your partners and others have been advocating for thinking about this idea of increasing investment in primary care and what that might look like. Can we talk a little bit more about, from your perspective, this idea of increased investment? How is it operationalized on the ground? What does it mean for patients and for access to primary care for New Yorkers and beyond?
Yes, so this is one of my favorite topics. So this is something that PCDC has been interested in and talking about for a very long time. I think what's important to understand about increasing primary care investment is that it doesn't mean increasing total spending, right? When we talk about increasing primary care investment, we're talking about rebalancing our healthcare spending. So, for context for that, right, it's estimated primary care gets only 5 to 7 cents on the healthcare dollar nationally. usually when I say that, a lot of people are surprised, right? It's abysmally low, especially in comparison to what our peer countries are spending. It's been shown that most OECD countries spend between 12 and 14%. And to talk specifically about New York, while we have some estimates, we don't actually know what New York State is spending on primary care. We don't have a mechanism for measuring, we don't have a technical definition. I think what we do know, and you're probably privy to this, Avital, is that New York spends higher than the national average per person in healthcare costs, but we consistently rank below a lot of other states in key health indicators. So that's backwards, right? And I think in order to improve the state's performance on both of those fronts, we really need to understand how much we're investing in primary care and figure out a way to then increase our support for those providers and services that keep people healthy. Because, it's the lack of investment in primary care and prevention that has left New Yorkers vulnerable to threats like COVID. And we've seen the effects of that, right? And like I said, I mean, in the wake of all of these things really being sort of front of mind for lawmakers across the country, but particularly here in New York, people are calling for systemic change and reform in order to improve access and quality of care. And I think rebalancing spending to invest more in primary care is part of how we do that. So you said, how is that operationalized? We can look to other states to sort of think about that. So let me just pull up my slides here one more time. Great. So, so we've got 10 states here. At this point, there's been 10 states that have acted in one way or another to begin defining, measuring, and in a lot of cases, actually increasing primary care spend. And the way that that's looked in most cases is states have convened a group of stakeholders to collaborate on developing that technical primary care definition, and then overseeing the collection of spending data to produce reports that show a measurement of primary care spend as a proportion of total healthcare spending. And so generally, these baseline measurements in each state of primary care spend are pretty in line with that national estimate of somewhere between 5 and 7%. And some states have gone even further than just measuring the baseline and have instituted spending targets or even mandated primary care spending increases. Like that could look like setting a very specific percentage target for a spending increase, like moving from 6% to 12% over a certain period of time. I think to look for examples of success, one of the best examples we have is in the pioneer state of Rhode Island. In 2009, Rhode Island's Office of the Health Insurance Commissioner required that commercial plans increase spending on primary care by 1% per year, so that by 2014, about 10.5% of total expenditures would be on primary care. Some of the evidence coming out of Rhode Island is that over the next few years after implementation, Rhode Island was the only state in New England to actually increase the supply of primary care physicians per capita, which is amazing. And all while spending by commercial health insurers actually slowed when compared with other states in that region. So given this, we know that total costs were not increasing, right? And in fact, there's evidence that during that same period, total expenditures actually decreased by 14%. So it's important to note that the ACA was also implemented during this time, which certainly had effects on demand and spending, but again, these correlations are really important. So I think just based on what we know about the health benefits and cost efficiency of preventive care, what we can expect to see over time with increased investment in primary care and prevention is better management and prevention of chronic diseases, which translates to decreased overall costs and most importantly, healthier communities, right? So with all of this in mind, I think it's just really exciting to see so many states taking action. And in fact, New York State is poised to be next. So the New York State Legislature recently introduced bills in both houses, sponsored by Assemblymember Dick Gottfried and Senator Gustavo Rivera. And they're actually both being considered in the health committees this week, which is really exciting. And the bill is very similar to a lot of bills that have been passed in other states. So I think it would just be great to see the same success here in New York.
Great, thanks, Maura. So that was a really helpful overview. I know there's lots that we could dig into on a variety of the things that you talked about today and presented. So what I think we'll do now is maybe we'll open it up for questions. So people should feel free, audience members, to chat us some questions in the chat box. I'll be keeping my eye on them, and I have been. And we'll kick off some of the discussion with Maura right now. So why don't we start with one of the questions that I think you touched on a bit as you started to talk through this idea of a definition of primary care, and really what the definition does for kind of setting targets in the future. Can you just talk a little bit more about what the various definitions that other states have looked towards to define primary care, what's kind of in and out, so to speak?
Yeah, no, that's a great question. It's so one of the things that would come out of this bill that's being considered here in New York is the development of a technical definition of primary care. So let's talk a little bit about what that means, right? So defining primary care for the purposes of measuring spending is different than defining it sort of colloquially, like the way that I was describing it earlier in our chat when I was saying, it's the foundation of the health system, the first point of contact. Defining for the purposes of measuring spending gets a lot more specific, right? Because you have to be able to actually sort of add things up that count as primary care spending. So most states thus far have come up with a definition of primary care that's made up of one, a set of provider types. So in other words, provider taxonomies or specialties like family medicine, internal medicine, and two, a set of services, usually using procedure codes. So like for a physical exam or a specific health screening. And these definitions are really varied across states. Some have taken a more narrow approach and only included a few provider taxonomies, and some have taken a much broader approach, like in Oregon, for example, they included psychiatry and OBGYN. And in the states that have convened a stakeholder group, like I was mentioning, to oversee these investment efforts, that group is generally charged with developing that technical definition. So stakeholder engagement is really important.
Got it. Great. And just kind of building off that, you touched on this as part of your answer to that question, but one of the questions has come in is, kind of what is the bill for? Can you just touch on the kind of bullets of what's in the bill in New York? It sounds like defining primary care is one of the items.
Yeah. Yes, so correct. The bill, again, very similar to the way that a lot of other states have gone about their investment efforts. The bill would convene a collaborative of stakeholders or a commission to oversee the development of that technical definition, and then also the collection of spending data across all payers in the state, to then produce a report delivered to the legislature that would show the baseline measurement of where we're at with primary care spending in the state as a proportion of total healthcare spending. And that report would also include recommendations for how to increase that proportion over time.
Got it. Okay, great. Thanks. And then, kind of the next question, I'm combining a few questions from the chat, but just, can you talk a little, you spoke to us a little bit about, what in some other states, what some of the increased investment might look like when what it translates to on the ground. What does it translate to in terms of access? What does it mean for patients? I think it would be great if you could speak a little bit more to that. And then also, one of the questions that came in is this idea of, and you might not have kind of some of the statistics on this, but what has the patients and consumers, what are they looking for in terms of access, and how might that have changed over the past year in terms of things like accessing care by telehealth or visiting urgent care, and what might that look like in the future? So maybe you could, kind of toggle between those two questions.
Yeah, no, that's okay. So that's a really interesting set of questions. So I think first, to sort of address the, translating these efforts of investment to, outcomes or access, ultimately, this is about keeping people healthy, right? How do we do that? We increase access to care, and then we increase the quality of that care. And so at this point, there's not a whole lot of evidence from these investment efforts in other states on how the initiatives have translated to access or outcomes, because most of the states are just in their fledgling stages, right? They've only just passed regulations or legislation within the last year or two. We do have some evidence from states that have been doing this the longest, like Oregon and Rhode Island. I shared a little bit of that with you from Rhode Island, but I think just in general, there is literature, to show that one of the reasons for a shrinking primary care provider workforce is the differences in payment between primary care and specialty care. That's one of the reasons that we've been seeing, some medical schools eliminate tuition for practitioners that are committed to going to primary care. So I think certainly one of the hopes is that this increased reimbursement and payment for primary care will build and also sustain the workforce. But in addition to actually increasing the number of primary care providers, we can't forget that these investment efforts will hugely benefit the providers that already exist, right? Increased investment can allow these providers to do their jobs better, more efficiently, and with less strain. That can lead to better quality care, particularly when the investment comes in the form of payments tied to value, right? More money in the form of capitation or incentive payments might allow a practice to hire additional staff or even seek to provide different types of services, maybe connected to social needs, or simply allow the provider to spend more time with patients. And I think to sort of get to that second question about what, the change in what patients have sort of been looking for in terms of access and quality over this last year, I think that really ties into this because, providers respond to that. And I think that, part of this investment can be used for transitioning care into this sort of new era of care delivery, right? That we've come into since COVID, that includes telehealth that we all know is very beneficial for a lot of patients. That includes, different types of care that can be provided under value. Switching over to this type of a care world is only supported by increased investment.
Great. No, that's helpful. And so let me pick up on one thing that you just talked about. It looks like we'll have time for about these two last questions. So we'll sneak in our two last questions that we kind of combination in the chat. So one of them is kind of building off what you just started to touch on around like kind of this idea of capitation. Obviously there's lots of discussions underway about kind of shifting from fee-for-service models to more of a prospective payment models. Can you tell us a little bit more about how some of these increasing investment initiatives relate to some of those maybe payment reform initiatives?
Yeah, so there's definitely some connections there. So in a lot of states that have implemented these investment efforts, the initiatives were actually tied to efforts to increase the proportion of payments that were made under value. So I think most advocates behind these efforts agree that increased investment should not just be coming in the form of claims-based fee-for-service payments, right? And most states to date in their investment efforts have acknowledged that by sort of attempting to include value-based payments in their spending measurements, which is not a perfect science yet, right? Measuring non-claim spending is proved to be a challenge because it's just not as straightforward as adding up fee-for-service payments. There are some great examples of success in doing this, like in Oregon, they created a template for payers to use to track and submit their non-claim spending. And actually, the Millbank Memorial Fund just put out a report that proposes a standard measurement methodology for exactly this type of spending, which was really great to see. But yes, so to your point, I think in general, there's increased recognition of the need to shift away from fee-for-service, particularly for primary care. I mean, this last year of the pandemic showed that this fee-for-service structure just does not support or protect PCPs financially in the face of emergencies. It sets them up for failure, right? In fact, in the recently and highly anticipated report on primary care from the National Academy of Sciences, part of one of their recommendations is that all payers shift primary care payment towards hybrid models, right? So part fee-for-service, part capitated. And I should also note, of course, that one of their recommendations from that same report is also that states begin to measure and increase the proportion of spending going to primary care.
Great, thank you. And so others can check out that too. We'll share that resource. So I think we don't necessarily have time to focus on our last question, but maybe you could just end by giving us one little note, and then we'll sign off in terms of how this relates to kind of specialty care and how increasing investment might tie to the other sectors of the healthcare system. What does that mean for the other sectors? It's just a nugget on that, and then we'll wrap up.
Yeah, no, it's a really good question. So I'll be brief. I think, to your point, increasing primary care investment is never meant to increase the total cost of care. But the thing that we need to think about or sort of recognize about other parts of the health system that is important is that primary care is being delivered in a variety of settings these days. In New York, for example, hospitals deliver a significant proportion of primary care, as much as a third is the number that I've heard. So rebalancing spending ultimately really is going to benefit everyone. And plus, as I mentioned before, stronger primary care means better care coordination with the rest of the health system. So everyone, specialists, hospitals, pharmaceuticals, everyone wants more efficiency in the system, and more investment in primary care is how we get there.
Great, thank you. So thanks everyone for spending an extra minute with us so that we could try to get to all of the questions. As I said before, we'll be sharing the recording and we'll be sharing some supplementary materials that I think will be helpful for the audience as part of our recap within the next few days. I'd like everyone to, also, if you check out our website, you can see other events that we have coming up in addition to today's. And I'd really just love to thank Maura for her time. This was really helpful, very informative in I know a short period of time. There's lots more to talk about. And so if anyone wants to connect with Maura after the session, I'd be happy to make that happen as well. So thank you for joining us, everyone, and have a nice afternoon.
Thank you so much, Avital. Thanks, everybody.
Thanks, Maura.